Welcome to the first Biotech Capital Compass podcast, where we explore innovations in biotechnology that help patients and physicians treat or prevent disease, starting today with HIV. Dr. Manish Sagar joins us from Boston University School of Medicine, where he's a professor and physician scientist specializing in HIV. His work spans treating HIV patients in outpatient clinics, consulting on prevention strategies, and leading research into how the virus spreads and causes long-term effects. We'll cover three areas: the disease itself and how it's treated, the market for patients already diagnosed, and prophylaxis for people at high risk. HIV is a retrovirus, meaning it converts its RNA into DNA. That DNA then slips into the host's chromosomes, creating a permanent infection the body can't clear. The virus likely jumped from chimpanzees to humans in the early 1900s through rare cross-species events. From Africa, it spread worldwide, becoming the epidemic we know today. Right now, 39 million people live with HIV, and about 40 million have died since it emerged. In the US, 1.2 million people have the virus, with 35,000 to 40,000 new cases yearly. Globally, new infections run around 1.2 to 1.3 million per year. We have powerful treatments and prevention tools, but no vaccine yet. If everyone at risk could access medications, all HIV transmission could be eliminated worldwide, though logistics make that hard to achieve. Dr. Sagar treats about 50 stable HIV patients each month and consults on 5 to 10 prevention cases. Let's talk about how patients get diagnosed and what testing looks like. Everyone in the US should be tested for HIV at least once in their lifetime, with follow-ups based on risk. Patients are found through routine screening, risk-based testing, or when symptoms appear, all leading to diagnosis. The tests are excellent, with over 99% accuracy in both specificity and sensitivity. Once diagnosed, the standard is to start treatment right away. Most regimens are single pills, with 2 or 3 active drugs inside, taken once daily for life. HIV makes copies of itself in the blood. Treatment keeps that replication as low as possible without eliminating the virus. The virus replicates, infects new cells, and without treatment leads to immune failure and AIDS. These therapies keep the virus at bay but don't cure it. Stopping medication lets the virus bounce back. Unlike some cancers that can be cured, HIV needs lifelong treatment, since nearly all patients see the virus return if they stop. Now, how do doctors choose which medication to prescribe? Biktarvy, a single daily pill with 3 active drugs, leads the field. The choice also depends on where you live, what insurance covers, and local healthcare preferences. Most HIV drugs are oral pills taken once a day. Cabenuva from GSK offers a longer option, 2 injections in the buttocks every 8 weeks. The field is moving towards 6-month injectables and possibly weekly or monthly pills. Because the patients need lifelong treatment and daily pills can be hard to remember, longer-acting options help people stay on track. Intramuscular shots like Cabenuva hurt more than subcutaneous ones, which feel like a flu shot. Cabenuva must be given by a trained provider at a clinic, adding logistical hassle. Gilead's lenacapavir is a potential 6-month injectable, though it still needs a partner drug. Lenacapavir goes under the skin in the abdomen, unlike Cabenuva's deeper muscle injections. Both still require a healthcare visit, which adds burden even with longer dosing. Let's shift to how the virus mutates and develops resistance. HIV mutates 1,000 to 10,000 times faster than COVID-19, which is why we can't make a vaccine. When patients take their meds consistently, the virus stops replicating, so resistance can't develop. Resistant strains to lenacapavir and Biktarvy do exist, but are rare. High potency, fast suppression, good adherence, and few side effects all work together to keep resistance uncommon. Now, what about side effects for people on lifelong treatment? Older HIV drugs had serious side effects, but today's medications are much gentler. Magic Johnson has been on treatment for over 30 years without kidney, liver, or heart problems. Current HIV drugs are actually safer than many medications for heart disease. It's rare now for patients to complain they can't tolerate their HIV medication. Let's explore the innovations extending how long between doses. Gilead is working on weekly and monthly pills, plus 6-month and possibly yearly injectables. About 90% of patients stick well to their daily pill regimen. Homelessness, financial stress, and mental health issues make it harder for some to stay on daily meds. Around 15% of patients currently choose the 8-week injectable. Needing a provider, scheduling visits, and handling costs all limit how many people pick injectables. Even without barriers, not everyone would choose injections. Many prefer the simplicity of a daily pill. Community clinics often lack the setup for injections, so those treatments concentrate in big academic hospitals. That means patients have to travel downtown, adding time and transportation challenges. Many find it easier to remember a daily pill than a weekly one. A monthly pill could be an appealing middle ground and might shift the market. Let's talk about what motivates patients who have HIV to stay on treatment. Staying compliant keeps the virus suppressed, controls the disease, and stops transmission. If they stay compliant, their chance of transmitting the virus is 0. Studies show patients can miss up to 2 pills a week and still keep the virus undetectable. Someone diagnosed at 20 faces 60 or 70 years of taking medication, which is a long haul. Now let's turn to preventing HIV in people at high risk. If we could get medications to everybody who's at risk, we could prevent HIV entirely. Prevention options include daily pills, 8-week injections, and 6-month injections. People are less consistent with prevention meds than treatment because there's no immediate threat. Gilead's lenacapavir offers 6-month prophylaxis with almost no transmission in trials. The big question is how to get these medications to the people who need them. Gilead agreed to lower prices for low-income countries, but not for middle or high-income ones. Whether US insurance will cover these expensive preventive drugs is still uncertain and may vary by region. HIV treatment costs about $500,000 over a lifetime, making it the priciest outpatient care in the US. Economic models show prevention saves money, but insurers don't always follow that logic in coverage decisions. So who exactly is at risk and should be offered prevention? Sexual contact is the main way HIV spreads around the world. In the US and developed countries, men who have sex with men face the highest risk. During primary care visits, taking a sexual history helps doctors assess risk and recommend prophylaxis. Anyone sexually active without condoms has some HIV risk, though it varies by location. After that group, people who inject drugs and share needles are the second highest risk in the US. PrEP use is lower than it should be because risk factors aren't always discussed or clinics aren't set up for it. Infectious disease doctors can consult on PrEP but can't provide ongoing care unless the patient gets HIV. Current PrEP reaches only 20 to 50% of at-risk people. The eligible population could be 5 times larger. Why is innovation in prevention so important for these populations? Like pregnancy prevention, HIV prophylaxis works best when people have multiple options to choose from. Daily preventive pills exist, but people struggle to take them consistently. Longer-acting injections help, but requiring clinic visits creates a barrier for healthy people. Healthy folks, especially in middle age, rarely see a doctor, making frequent prophylaxis visits tough. 6-month dosing means fewer visits than 8-week dosing, easing the burden. Other prevention methods beyond pills and shots are available outside the US. Giving people as many options as possible to prevent a lifelong disease is key to stopping transmission. Let's touch on a few other factors in HIV prevention. Rates of gonorrhea, chlamydia, and syphilis have been climbing in the US. Adapalene vaginal ring offers longer duration prevention and is used in Africa, but not here. Finally, what excites Dr. Sager most about the future of HIV care? Stigma around HIV still drives patients to prefer injections over carrying pill bottles. The push for a cure is strong because patients want to shed the lifelong stigma of infection. Some people have been cured, but the methods are extreme and only for the critically ill. Gilead's lenacapavir paired with a new integrase inhibitor for 6-month dosing could transform the field. Daily pills will stick around for patients who prefer them, but injectable use will grow. Merck is developing doravirine and islatravir as additional treatment options. Islatravir was meant to be a 6-month or yearly pill, but had side effects, so it's being reworked for weekly dosing. Islatravir looks especially promising for prophylaxis once it's ready. Small biotech companies are researching cures, though none are close to phase 3 trials yet. The ultimate goal is turning HIV from a chronic condition into a curable disease. Moderna is using mRNA technology to work on both a cure and a vaccine. Moderna's trials are planned but haven't started, and Dr. Sager is cautiously optimistic about their impact. Let's close with some reflections on how far we've come. In my 20s and early 30s, HIV and AIDS were topics that one couldn't really discuss out in the open. Today's conversation shows how we can now focus on science, innovation, and clinical practice in an open